Hey, future clinicians. So today we are talking about allergic conditions. This is our short note today, so watch the video till the end. You can refresh what you have studied and learn something new from this. We are going to cover every important point. Do not skip anything. First, let's start simple. Do you know what actually causes an allergy? Allergic conditions are due to hypersensitivity reactions. That means the immune system is overreacting to something that is usually harmless. And in most cases, this reaction is mediated by IgE antibodies. You can explain IgE like this. It is a special antibody that sits on mast cells, and when an allergen comes in, it triggers histamine release. That is why you get symptoms like sneezing, itching, swelling. Common allergic conditions you must remember: allergic rhinitis, also called hay fever, urticaria, which is hives, angioedema, deeper swelling, and the most dangerous, anaphylaxis. Now let's move into antihistamines, very important for exams. All antihistamines are mainly used for allergic rhinitis, especially seasonal. So when patients come with pollen allergy, this is your go-to group. They also help in general nasal allergies, but in vasomotor rhinitis, they are less effective. Now think clinically. They are very good for runny nose, sneezing, but not very good for nasal congestion. That is a classic exam point. Now about how we give them. You can use antihistamines in different ways: topical forms like eye drops, nasal sprays, skin applications, but most commonly we use oral tablets. Let's expand a bit. Antihistamines are not only for rhinitis, they are also useful in urticaria, pruritus, itching, insect bites and stings, drug allergies. And here's something important. After stabilizing a patient with anaphylaxis, you can give antihistamines for skin symptoms only. Now, here is something interesting. Some antihistamines have additional uses. For example, nausea and vomiting, migraine like buclazine combinations, even occasional insomnia. So they're quite versatile. Now let's talk about sedation, very high-yield concept. All first-generation antihistamines cause sedation. Yes, all of them. Some are more sedating like elimimazine, promethazine, and some are less sedating like chlorphenamine, cyclizine. Here's a clinical tip. Sometimes we actually use this sedation effect therapeutically. For example, in patients with severe itching at night. Also remember, there is no strong evidence that one antihistamine is superior. Patient response can vary a lot. Now, second-generation antihistamines. These are your non-sedating drugs. Examples you must remember: cetirizine, loratadine, desloratadine, fexofenadine, levocetirizine, bilastine, mesalastine. Do you know why they are less sedating? Because they do not cross the blood-brain barrier significantly. So less effect on the brain, less drowsiness. Important for elderly patients, first-generation antihistamines are not preferred. Why? More sedation, more side effects, higher risk of falls. So always prefer non-sedating antihistamines in elderly. Now let's move to allergen immunotherapy. This is basically desensitization. We give small controlled amounts of allergens so the body gradually becomes tolerant. Common allergens used: house dust mite, animal dander like cats and dogs, grass pollen, tree pollen. What are the benefits? It can reduce asthma symptoms, allergic rhinoconjunctivitis. Now, a very important type, venom immunotherapy, used for bee venom, wasp venom. This is done to prevent severe anaphylaxis in future. There is also oral immunotherapy. For example, grass pollen for rhinitis, house dust mite for asthma and rhinitis. And very important, peanut desensitization. Peanut protein is given in controlled doses, usually started in children and continued into adulthood. Very important rule: all immunotherapy must be done under specialist supervision, usually in a hospital setting, because there is always a risk of severe reactions. Now, a very important exam drug, omalizumab. This is a monoclonal antibody. Mechanism is simple. It binds to IgE and prevents allergic cascade. Uses severe allergic asthma not controlled by high-dose corticosteroids plus LABA, chronic spontaneous urticaria when antihistamines fail, and remember, it is only given in specialist centers. Now we come to the most dangerous condition, anaphylaxis. This is a severe, life-threatening systemic hypersensitivity reaction. It has a rapid onset, and it affects airway, breathing, circulation, often with skin changes like rash or swelling. Common causes you must memorize: foods, peanuts, shellfish, milk; drugs, antibiotics, NSAIDs, vaccines; others, insect stings, latex. Risk factors include asthma, repeated exposure to allergens. Now, management. This is extremely important. Step 1, call for help immediately. Start CPR if needed. Step 2, remove the trigger. Stop the drug, remove the stinger. Step 3, positioning. Lay flat with legs raised if shock. Sit semi-upright if breathing difficulty. Recovery position if unconscious. Pregnant patient, left side. Step 4, the most important step. Intramuscular adrenaline, also called epinephrine. Give it immediately. Do not delay. Step 5, monitor the patient. Blood pressure, pulse, breathing, consciousness. Step 6, repeat adrenaline after 5 minutes if needed. Step 7, if no response after 2 doses, this is refractory anaphylaxis. Step 8, supportive management. High flow oxygen, IV fluids for shock, nebulized adrenaline for airway edema, but only as adjunct. Step 9, antihistamines, not first line, only after stabilization, example, cetirizine. Step 10, corticosteroids, not routine, use only in refractory reactions, asthma, shock. Step 11, bronchodilators, salbutamol, ipratropium, only as adjunct therapy. Refractory anaphylaxis means symptoms persist after 2 adrenaline doses. Management includes IV adrenaline infusion, ICU care. If IV is not available, repeat IM adrenaline every 5 minutes. Before discharge, very important steps. Give the patient 2 adrenaline autoinjectors, teach how to use them properly, and tell them always carry it. Patient education is key. Avoid triggers, be aware of biphasic reactions, have an emergency action plan, and always refer to an allergy specialist. Now let's talk about angioedema. This is swelling of deeper tissues. Common areas, eyelids, lips, tongue. If severe, treat it as anaphylaxis. But here's a very important difference. Hereditary angioedema. In this condition, adrenaline does not work, antihistamines do not work, steroids do not work, completely ineffective. So what do we use? Treatment includes C1 esterase inhibitor. Other options, icatibant, conistat alpha. For prevention, tranexamic acid, danazol, but avoid danazol in children. Newer prevention options include lanadelumab, berotralstat. So now you can clearly understand how allergic conditions develop and how we manage them step by step. From simple antihistamines to life-saving adrenaline and anaphylaxis, everything connects through one key concept, IgE-mediated hypersensitivity. Take a moment and quickly revise these points again, because these are very high yield for your exams. And in the next video, we are going to explore something very interesting, conditions affecting sputum viscosity. You will understand why mucus becomes thick and how we manage it clinically. So don't miss that lesson. If this helped you, make sure to like the video, share it with your friends, and subscribe for more simple medical learning. I will see you in the next class.